Hello, everyone. Good evening, and welcome to Weill Cornell Medicine's educational webinar series. We'll just take a few minutes to let everyone join, and I see we've got a good amount of people. Please feel free to drop where you're joining from tonight in the chat. I'm Rebecca. I am in Brooklyn, New York. Tonight we're joined by Dr. Gabriella Tosto-D'Antonio, who I believe is in Manhattan.
I am actually in New Jersey tonight.
Oh, you're in New Jersey. Okay.
Yes.
Great. I'm seeing we've
Just-
also got some fellow Jersey Jersey people in the chat. Love that. And if you're just joining, please feel free to drop where you're joining from tonight in the chat. So I'll just wait one more minute before we get into our housekeeping items. Let everyone come on. Okay. Amazing. Well, good evening again, and welcome to our educational webinar series. I'm so thrilled to be joined by Dr. Gabriella Tosto-D'Antonio. Before we get started, a few quick housekeeping items. So this session is being recorded and will be available within 48 hours or so. It'll be sent to the email that you registered with, and it will also be available on the Weill Cornell YouTube page. Please keep your microphones muted throughout the presentation. We will have a Q&A section at the end of the presentation. You can submit your questions anytime using the Q&A feature or the chat. I know that some of you submitted beforehand through the Zoom registration, and we have those noted down. So thank you for doing that. And it is Heart Health Awareness Month, and we are doing this webinar as part of the I Heart Your Heart series through Weill Cornell Medicine. And you can learn more about heart health and how Weill Cornell can help you with your cardiovascular health at the link I am dropping in the chat right now. Let me just put that in there. And yes, Judith, the recording will be available after the meeting. It will be sent to the email that you registered with. It will also be available on our YouTube page. Fantastic. So it looks like we have a good group on the line. I am gonna dive right in. So I'm so excited to introduce tonight's speaker, Dr. Gabriella Tosto-D'Antonio, DMP, who is our Chief Nurse Practitioner for the Department of Neurosurgery at Weill Cornell Medicine. Dr. Tosto-D'Antonio earned her Doctor of Nursing practice from Columbia University, where her doctoral work focused on transitions of care models, preparation that serves her well in the complex world of neurosurgical practice. She brings a holistic, patient, and family-centered approach to care and is passionate about interdisciplinary collaboration and operational excellence. Um, I'd love to hear when I came to Dr. Tosta D'Antonio with this topic, she was so excited, and I'd love to hear you just elaborate a little bit on why you love this topic.
Yeah, thank you, Rebecca, so much. I think this is one of my favorite topics because we can empower our patients and ourselves to actually make a difference in our cardiovascular and cerebrovascular health. A lot of things we cannot control, but this is something that we actually have some ownership over. So I'm excited to talk more about educating everyone on how to perfect that as best we can and give yourself the best further outcomes as we all get the privilege of getting older.
Yes, love that. Um, and we're gonna start tonight by getting to know you all a little bit. I am gonna launch our first poll. So I'll give everyone a minute to respond and then we'll share the results. But what brings you to tonight's webinar? Are you interested in protecting brain health as you age? Do you have risk factors that you want to understand the brain connection a bit more? Are you supporting a loved one with risk factors? Are you in healthcare, just interested in brain health or other? And if you choose other, feel free to drop it in the chat or elaborate if you choose any of our other options. Okay, I'm going to end the poll. We've been going for about a minute. And share results. So most of us are interested in protecting brain health as we age, which is really interesting and great for us to know. But some of us have some cardiovascular risk factors, some of us are in healthcare, and I'm sure we're all interested in brain health topics. So fantastic. Love to hear it. Thank you for being here. We really appreciate your time. And with that, I am going to pass it over to Dr. Tosto-D'Antonio for her presentation.
Thank you so much, Rebecca. So when we talk about brain and heart connection, we want to understand how these two different organs, these two different systems of the body interact. So I like to tell my patients and my family members, the heart and brain are all part of the same plumbing system, right? So I'm going to make a few references with respect to pipes and things like that. You do not have to be a plumber. If you are, maybe you'll get this more than some of others, but in general, this is just an analogy, right? So when we talk about the heart, we all can understand that the heart feeds the brain. Your brain uses about 15 to 20% of your body's total blood supply. Uh, every single heartbeat delivers oxygen and nutrients essential for our cognition, as well as other functions, right? Me speaking right now, you understanding me, it's all pumped from the heart. On the other hand, the brain controls the heart. So your brain is responsible for regulating heart rate, your blood pressure, and your stress responses through something what we call the autonomic nervous system. This is a network of nerves that controls your unconscious processes such as breathing, your heartbeat, digestion, etc. You're not even aware of it, right? But it's still happening every second of your life. So because of this relationship, essentially we have shared risk factors. So many conditions that can harm your heart also can harm your brain. So making this, whole talk, the point of this whole talk being how we can actually prevent either of these organs from receiving damage over the course of your life. Next slide, please. So what are some common cardiovascular risk factors, right? Again, these are risk factors that are affecting both your heart and your brain health. We're going to talk a lot about high blood pressure today. High blood pressure is damaging blood vessels throughout the body, including these tiny, tiny, delicate brain vessels. We'll be talking about high cholesterol. And so maybe your doctor have said, oh, your cholesterol is borderline, or oh, actually, it's a little higher than what we like. This is a number that represents plaque that's built up in your arteries over time, reducing blood flow to the heart and the brain. We will talk a little bit about obesity and weight and how that increases strain on the cardiovascular system and promotes chronic inflammation in the body. We'll touch upon diabetes, right? So high blood sugar that can accelerate vascular damage and inflammation of the body. Smoking, which constricts blood vessels and promotes inflammation as well through these vessels, as well as a sedentary lifestyle. So lack of physical activity weakens the heart and reduces brain blood flow. Next slide. So the plumbing connection. So when we talk about issues with the heart, there are common issues. We're just going to go over the basic ones here, particularly with valves. So your heart is made up of numerous valves that help pump blood in sync and across the body. So some people may have heard of valve regurgitation. That is when the heart's valves are leaky, resulting in a weaker arterial pressure to the brain. So if you can imagine a valve acting kind of like a trampoline over time, and it's supposed to be sinking and pumping in sync. Sometimes these valves don't actually open or close the right way, resulting in blood not getting pumped through the chambers correctly. So these valves that may have regurgitation can cause lightheadedness, some dizziness, fainting. Patients have reported feeling some confusions, as well as something called a TIA or transient ischemic attack. Another part, we can look at atrial fibrillation. This is when the heart beats irregularly. So the heart is supposed to, again, be in sync, but sometimes the heart can beat irregularly, causing pockets where tiny, tiny blood clots can form and then travel to the brain, causing an ischemic stroke. So an ischemic stroke, if you think of it in simple terms, it's a blockage, right? A blockage in an artery of the brain. So some patients, when they're diagnosed with atrial fibrillation, they are started on a medication that's an anticoagulant or a blood thinner. Common one is Eliquis. In some patients where there's an actual ischemic stroke and a blood clot is blocking a large vessel of the brain, cause a large vessel occlusion, our neurosurgeon or neurointerventionologist has to do a thrombectomy. And you can see in the picture on the left-hand side, these are two surgeons who are performing essentially a thrombectomy. It's done when we take a tiny tube, we enter it either into the wrist artery or to the artery in the leg, the femoral artery. And with the contrast and CT navigation, we're able to direct that tiny, tiny tube all the way to where we see that blood clot form. Once we get to that place where we see the blood clot form, we're able to essentially suction it out or grab it with a stent retriever and pull that tiny blood clot out and reopen the vessel. And as you can see on the right-hand side, you'll see A, B, and C. A being a angiogram of a patient who has a stroke, who has a blockage, and you can see that there's no blood actually going beyond that one point that just kind of cuts off. You can see in picture B, that patient had a few blood clots along the way. And so the neurosurgeon was able to retrieve those blood clots successfully. In picture C, you can see that now that blood is completely restored to the brain. And so we do this in an emergency to prevent any further damage to the brain itself, as well as preserve function in a patient. Next slide, please. So over the course of people's lives, again, with the privilege of all of us getting older, there is something called atherosclerosis, which is high cholesterol levels over time, leading to buildup of plaque in the arteries. And this buildup essentially can narrow the arteries in the brain and the heart. So again, coming back to my plumbing and kitchen references, think about when you've put too much cooking oil and grease down your kitchen sink, right? Over time, you try to do dishes, and we've all been there. We try to do dishes and the water's not going down the drain, and the water's not going down the drain. And then we have to either ask our husband or partner or friend or plumber to come and help us clean that out, right? So in that same vein, we as providers can prescribe medications to help to overcompensate and to overcorrect those issues. So there's a lot of conversation about medications like antiplatelets, aspirin being one of the original, if not the original, antiplatelet medication. It helps prevent the blood platelets from getting too sticky and helps blood flow a little bit smoother. Statins, such as Lipitor or Crestor. Again, it's a privilege of getting older. Many people over the age of 50, it's kind of like a rite of passage where many times we all have to go on a anti-lipid or statin rather. And so over time, taking these medications help reduce the amount of atherosclerosis that forms in the vessels of the body. If you look to the right, you can see that in this picture, there is a artery, and you can see that there is what we see carotid stenosis. And again, this is demonstrating that plaque buildup inside what we know as the internal carotid artery. It's an artery that goes from your carotid in your neck up into the internal carotid artery of your brain. And so we see this plaque buildup, and that can cause people problems, right? It can cause symptoms. It can it can hurt blood flow to the brain itself. And sometimes blood clots can form in these different nooks and crannies of plaque and then eventually go downstream and cause a stroke. So if medications are not working, and that happens for all different types of patients, some patients just have, unfortunately, poor genetics that you can't control. Other people, need to better understand their risk factors, perhaps take better medication or different medication combinations. In some patients, though, we need to do a little bit of rerouting of these vessels. So in the bottom picture, you can see a demonstration, an illustration of a carotid endarterectomy. Essentially, we go in and we open up the artery in the neck, the carotid, and we identify where a large plaque is, where there is some severe narrowing. And a neurosurgeon will go in and essentially take out that plaque. So it's kind of like snaking your pipe, right? In patients who perhaps have either had a carotid endarterectomy or people who maybe had radiation to their neck from cancer, for neck cancer. Sometimes we can't get into the actual artery itself. So then we're able to instead go and perform a carotid artery stenting. And that's done similarly to the thrombectomy that we spoke about previously, where it's done under anesthesia with X-ray guidance, and a neurosurgeon will go in either through the wrist or through the femoral artery, and they'll essentially direct a carotid artery stent to the carotid artery, open it up, and you've got yourself a brand new wide open artery, and blood flow resumes as it should, which is pretty nice. Next slide, please. Another point to mention with cardiovascular risk factors for cerebrovascular and brain health is uncontrolled hypertension. And so high blood pressure over time can cause major damage to the arteries and smaller blood vessels. So if you can imagine a faucet being on at full blast all the time, that's not really great for an artery that's supposed to be under a certain pressure at all times. So over time, these arteries can become weak, right? It's constantly being berated by high flow that it's not meant to take over time. And eventually these can burst, right? So pipes can burst if there's too much high pressure. So in some patients, it could be a very small bleed. Sometimes patients just report of having headaches, and then we do an image for something else, and we see maybe they've had a small stroke. In other cases, there is sometimes a significant bleed, right? Where, as you can see in the bottom pictures on the left-hand side, we see what was known as a basal ganglia stroke. It's part of the brain where hypertensive strokes occur or hemorrhagic strokes. And sometimes we need to perform an evacuation, a craniotomy to evacuate the blood. That's due because of a certain amount of volume is supposed to exist inside of the skull. And if you bleed into your skull, that increases the pressure and could cause major brain damage. So our neurosurgeons are excellent at going in and releasing this hematoma, as something we call it, or blood that's in that space to help relieve the pressure essentially from the actual bleed itself. Next slide, please. So all of that doom and gloom, what do we do about it, right? How can I make sure this doesn't happen to me or happen to my loved ones, right? So we talk about blood pressure. Our goal blood pressure for patients is 120 over 80. So 120 is a systolic number, the number at top, and 80 is the diastolic number at the bottom. Again, high blood pressure is the strongest modifiable risk factor for both your stroke risks as well as your cognitive decline. As we get older, sometimes our blood pressure gets a little low, I will mention. So I've had patients where their blood pressure is a little bit 90 over 60 on a good day. And those are different situations that we can always talk about offline. But for this talk and for this particular instance, our goal is around 120 over 80. Now, I do have some patients who see me in a white coat, freeze. I look at their vitals and they're a little high. We call that white coat hypertension. I try not to wear my white coat if I know it's that high and try again. But some patients overall do have higher blood pressure. So there's different categories, and that's something that we'd want you to work with your primary care doctor, right? Your PCP or general practitioner or cardiologist if you have it. Cholesterol, so the LDL, so the LDL is the bad cholesterol as we call it, right? We want the L, I always say L for lower, right? L for lower is better. We want the LDL target to be below 100. Elevated LDL is known to contribute to arterial plaque, like we just spoke about. That can restrict blood flow to the brain over time. Additionally, blood sugar, everybody's weakness, at least it's my weakness for sweets. We want our A1Cs to be below 5.7. Diabetes and prediabetes significantly increases the risk of vascular cognitive impairment. So knowing your numbers is essential, is very important. Regulatory monitoring helps you catch problems early, right? And this is something that we can fix. It's important that you make sure you talk to your doctor about your cardiovascular risk factors and what it means for your brain health and what you can do about it. Next slide, please. So what does the research give us, right? We talk about research all the time. Your doctors and other specialties probably bring up a lot of research. So here's some more. So around 50% of dementia cases do have a vascular component. Two times the likelihood of a higher dementia risk with untreated high blood pressure, right? And 1 in 3 adults that are diagnosed with dementia have at least one cardiovascular risk factor. So taking all those tough numbers leads us to understand how can we really better our cognition over time. So midlife cardiovascular health, right? Midlife being late 40s, 50s, 60s. That's what I like to deem as midlife. So midlife cardiovascular health strongly predicts, meaning it strongly indicates that predicts and can determine how good or how poor your late life cognitive function will be. Each cardiovascular risk factor increases your cognitive decline risk independently. Brain changes begin 20 years prior to symptoms starting. Unfortunately, we don't have the MRI technology standardized yet, where we can say at this point in time, we can for sure say somebody will develop a type of dementia or not. They're working on it. The technology just needs to catch up to our big ideas, I think. But in the interim, we like to manage these risk factors that can slow or prevent cognitive decline. Next slide, please. So my old adage of what's good for your heart is good for your brain. I preach this every time I see somebody because I think it's just so important, right? So the same lifestyle choices that protect your cardiovascular system or your heart are also going to preserve your cognitive function. So we talk about healthy diet. And some people had asked in the questions prior to this webinar different types of diets that may help. And I'm no nutritionist, but this is what the research shows. Referring back to the Mediterranean diet, right? So, um, certain fish like salmon, leafy greens that have folate in it. Olive oil is your friend. Go crazy. It's good for you. Um, Walking, a little bit of wine, but not too much. Just a little. A little bit of red wine specifically. Um, Legumes, right? Certain nuts and exercise. Those are the highlight reel of the Mediterranean diet, and that's what's really best for you and what's been shown on the research to help promote longevity and good longevity, getting old and actually enjoying being old, right? That's important. Regular exercise. So nobody says you have to go run the New York City Marathon, although if you do, congratulations. But getting out and walking, although we've been a little challenging this past week with almost 2 feet of snow, getting out and moving it, right? So nobody says you have to go walk 10 miles a day. If you do, that's great, but 30 minutes a day of moderate exercise. Moderate meaning you get a little sweaty, you get a little short of breath, right? And you walk Central Park Loop once is perfect. Doing that 150 minutes a week. How you split it up is up to you. That's been demonstrated to improve cognition, improve cardiovascular and cerebrovascular health. Quality sleep is always everybody's literal worst nightmare. It's very hard to get good sleep. And so practicing good sleep hygiene, right? Getting off of our phones, our TV, less news, maybe a little bit more reading, making sure you protect the hour or so before bed, really winding yourself down appropriately allows you to have better sleep versus staying up all night. It's very difficult, but it's over time, quality sleep has been shown to help improve cognition and brain health. Stress management, which we all can laugh and say, yes, that's so much easier said than done. But working on how we can regulate our emotions and our stress is very important, right? So deep breathing exercises, what I like to call going for a lap if you're having a tough time at work or during your day, going for a quick lap, right? Resetting yourself. How that does add up over the day and over the weeks and over the years of your life. So trying to practice patience with yourself and others that will help you with your stress over time. And my biggest no-no is no smoking, including cigarettes or vaping, right? We don't want to increase the inflammation or delivery of chemicals to the vascular system that will circulate basically through your heart and through your brain. Next slide, please. So again, just bringing it back to some numbers, key targets for heart and brain health. Your provider, your doctor may have different goals for you if you've got different other comorbidities or other diagnoses, but this is just for general information. This is from the American Academy of Heart Association. They are the ones who promote these numbers. So again, blood pressure below 120/80. This protects small blood vessels from essentially being in high flow all the time, being damaged by that high flow. It can prevent silent strokes. L's, right? We want low LDL cholesterol below 100. That reduces the amount of plaque buildup in the heart arteries and the brain arteries. Your fasting blood sugar. So if you go in the morning to the Star Pavilion to get blood done in the morning on the KO9, we want to make sure that if you hadn't eaten breakfast, when we do a quick finger stick of your glucose. We want that to be below 100. That is a indicator of your overall ability to metabolize glucose. And so preventing vascular damage from high glucose, that is very important. So just being mindful of those numbers. On that same vein, right, A1C, that is a marker of glucose metabolism over the prior 3 months. So I've had patients in my prior life, tell me, oh yeah, well, I dieted 2 weeks before I came in from A1C. And I was like, well, that's not good enough, because it does show what glucose levels are over the course of 3 months. So that is a number that demonstrates that average over that course of time. So um, that number is indicative of your long-term glucose control and overall inflammation status. BMI, right? So, and this can be tricky. The target again is between 18.5 and 24.9. But I think that comes with caveats. If you've got a large BMI and you're also a bodybuilder, that's very different if you have a large BMI and have less muscle mass, right? I also understand some people are just built different. But really trying to stay around that 24, 23, that I think to me is healthy. Um, and again, the healthy weight reduces the strain on your cardiovascular system. Your body has to move less mass through space when you walk and when you move and when you run or skip or take the subway stairs. So promoting and maintaining a healthy weight is essential for your cardiovascular system. Next slide. So when should you seek care, right? All of this is well and good, but what do you do about it, right? Or what do you do if you need guidance? So I like to first start with emergency symptoms, right? And I tell my patients when I see them, if you start to have any signs of sudden confusion or difficulty speaking, you've got the worst headache of your life, like somebody hit you in the head with a baseball bat. Yes, that's severe. You've got sudden vision changes, right? Your vision goes blurry. You start to experience having a curtain come over down in one eye, like almost like half of your vision went out. You suddenly have double vision, right? And you weren't just staring at your screen or telephone for an hour. You've developed weakness or numbness on one side, or you have sudden difficulty walking or with your balance. Those are emergency signs. That is a comes to our emergency room if you're in the area. If you're not in the area, go to your local emergency room, right, to seek emergency care. Those are signs of a stroke. So we want to make sure that you get the care ASAP. The saying in neurosurgery and neurology is, time is brain, right? So every minute counts. Um, do not try to sleep through it and think it's going to go away. We'd rather you come in and we'd rather see you in the emergency room to make sure you're okay. All right. Um, at a more longitudinal level, if you start to notice these chronic symptoms, right? You start to notice your memory is a little bit different, that it's affecting your daily activities. There is a threshold of, again, all of us getting the privilege of getting older, right? So our memory in general may decline as we get older over time. But these are pretty significant changes in memory where, again, you may get lost in familiar places. You may have trouble finding words or following conversations. Forgetting names, I think, is a gray area, but forgetting the names of the people you're very close with all the time is more concerning to me. Difficulty focusing and constant mental fog that you just can't shake out of. If you notice or if somebody else notices perhaps a change in your mood or personality, or you're making, interesting choices and judgment calls, right? These are things that signs and symptoms that come on gradually. They're a little insidious. You don't really recognize it. But if you do, we would recommend you bringing it up to your provider, whether it's your general practitioner, or your cardiologist or neurologist, or even us in neurosurgery. We'd like to hear about it. And we can further evaluate you possibly if there are neurological reasons to maybe image you differently, or to have you complete a neuropsychological assessment. So don't be shy. It's better to understand what the symptoms are if they exist, so we can identify them and work them up appropriately if necessary. And again, primary care, cardiologist, neurologist, us in neurosurgery, we're always here to help coordinate that care. Next slide. So I have a few take-home messages I think I'll deliver today. The biggest thing I hope you take away from this is that you have the power to protect your brain by taking care of your heart, right? So knowing your numbers is essential. Going for regular checkups and monitoring gives you the control over your own health trajectory, right? You're in the driver's seat. You're the quarterback of this game. We've got one shot at it to get it right. And so there are easy, I think, and creative ways that we can all work on improving our cardiovascular health and improving our brain health as they share that relationship. It's never too late, right? So if you say, oh, I'm 65, somebody told me last week, I'm 65, I'm not going to start going to the gym. That's not okay for me, right? Again, nobody's saying you have to go do a bodybuilding contest or run the marathon, although you're more than welcome to. But just starting somewhere, right? It's just something little every day. Just take a half hour for yourself, right? Take that time to decompress, to get out there and go for a walk, uh, or go to the gym. Start something new. Make it fun for yourself. I think that's important. I think it's easy to get a little bored when we get into the same routine. Engaging with your community, right? Joining clubs and things like that, where people do different physical activities, I think is amazing for people. Talking about diet and how you can better your diet. Now with the internet, none of us have really an excuse, I don't think, in terms of what we can, create with these amazing dishes. Um, I know you've probably heard of the DASH diet. We've talked about the Mediterranean diet. Now the new thing is they've come up with the MIND diet, MIND, and that's like a combination of everything. So it's the Mediterranean dash intervention for neurodegenerative delay. So it's all of these combined into one. I actually had to write it down because it has such a long name. And it's got the best of everything, in my opinion, right? So again, what we talked about, leafy greens, that gives you that extra folate. Whole grains are important, and legumes. Olive oil is your friend. As you see, my name is Italian, so I love olive oil. You can't get enough of it. Berries, which have antioxidants that help protect your brain from waste, natural waste that the brain gets rid of. Nuts, which are good in protein. And fish, certain fish, not all fish, right? So salmon, mackerel, sardines, things like that. Um, Obviously, moderating these diets depending on where you are in your hypertension journey. You don't want to have too much salt. That's part of the DASH diet. So you want to be mindful of your salt intake as salt increases high blood pressure. And you want to make sure you get enough, uh, like I said, salmon. Walking is very important as well. And a little bit of red wine is good for you. So managing these risk factors truly can slow or prevent your cognitive decline over time. Don't wait for the symptoms, right? When you go for your annual physical, bring it up to your primary care doctor. I'm 90% confident they will be just as happy to talk about it as I have been today so far, because it's something that makes their job and their relationship with you very easy because it's something that you can work on together. Now, there are some people that no matter what you do, whether you're a marathon runner, or you do crazy sports, sometimes your genetics, unfortunately, take over, right? And so, unfortunately, I've had patients where they've done all the right things, and sometimes their cholesterol's still high, and they come to me and they're like, "Why is my cholesterol still high?" Or they're doing everything right, they've never smoked, and they've got other vascular issues, and so I always tell them that even though your genetics are there, the ability to modify these other risk factors help you really prevent any additional issues from occurring. If you had not done those things, then we don't know where you would be in, or what position you'd be in at that point. So continuing to take that lead, don't just get discouraged if even if you're doing everything right. It's easy to get discouraged when your numbers still are not behaving despite your best efforts. But just imagine that if you hadn't been doing that best effort, what those numbers would even look like. They'd probably be a lot worse. So again, having this conversation with your provider, I think, is essential, and something that you can correct over time. Next slide. So how do we do this at Cornell? We have a great interdisciplinary team and something that Rebecca touched upon when she was introducing me. So I like to go through this because I think it's important to understand which role we all take. So neurological surgery, right? So our department's made up of neurosurgeons as well as nurse practitioners and physician assistants. And so we provide expert evaluation and advanced treatment options. I like to say we're kind of like the carpenters of the body, or the carpenters of the brain and the carpenters of the spine. So we're there to do structural work, to fix your artery if it's a little too narrow, to treat an aneurysm, to help you with any and all structural issues of your brain and spinal cord. Your cardiologist is responsible for your heart, and local artery and plumbing. Right, so they are able to perform a comprehensive cardiovascular assessment and management with medications and possible interventions, surgical interventions if you need it. Your primary care provider, your PCP, they're the ultimate, middle person, middle ground messengers, also quarterbacking a lot of the care coordination. So they're at the forefront of helping identify these issues, and escalating you to the proper specialist if you need it. And of course, we all provide excellent patient education. That is our goal. That is our mission. We want to empower you with the knowledge for the best outcomes, right? So we can work together. So our commitment to you, of course, it's evidence-based, right? We talked about some literature today. We want to personalize it for you. So what might have been presented today at this presentation may or may not fit you, and we can help identify those areas if you need it. We clearly communicate these steps with you. We want to focus on prevention and wellness, and we want to collaborate with you, and ongoing support and education for you. Next slide. We heart your heart. We love your heart. And here's the information on how you can learn more about our
Yes.
program that we have.
Sorry, excuse me. So we are going to go into the Q&A section.
Perfect.
So the first question that comes from our you've touched on this a little bit, but I'd love to go into it a little bit more because I think it does really come up for a lot of people. How important is genetics in cholesterol and heart disease?
Yeah. So, like I mentioned, genetics is something we cannot control. It is our DNA. It is something that, as much as we'd love to change certain things, we cannot. So genetics are basically the DNA of your cells, right? That determine how your body, not only what color hair you have, what color eyes and things like that, but also determines how your body metabolizes cholesterol or works on it, right? We talk about, oh, I've had patients say, oh, my metabolism is so slow. And a lot of times it's genetic, right? And there's some people who have really fast, better metabolism, just like some people are meant to run faster than others, no matter how hard we try, right? So genetics are the blueprint of each of us and how we function and how our individual systems of our body function. So our genetics determine how our body, again, utilizes glucose, and turns that either into energy, right? Converts it either into energy or converts it into fat. And sometimes people have genetics where, again, their DNA says, yes, burn this off faster than, say, 10 other people or in a room. Other times, people genetics wind up saying, hey, you know what? Let's just store that a little bit more. We like that. And that's totally, and we have no control over that, right? All of us in this room could eat the same meal and we are all going to metabolize it differently. And that's based off our genetics. So again, there's patients I've had where their genetics, they don't maybe eat the best mind or Mediterranean diet, and their weight's good and their numbers look great. And I'm mesmerized and I'm stunned because, theoretically, they should have higher cholesterol and they should have a higher A1C and fasting glucose. Um, and then I have other patients where they're doing everything to a T. They're the best eaters. They've got the best diet. They've got a nutritionist. They work out every day, and their numbers are still high. So knowing what your numbers are really important because no matter what your genes say, no matter what you eat, the numbers don't lie. And that's how we standardize it across all of us who have different genetics that, again, metabolize or utilize different nutrients and fats and cholesterol, et cetera. So medically, we use that number to, again, with research that we've studied millions of people over the last 60, 70 years, right? We've been shown to say this number for a high cholesterol has this X amount percent risk of a heart attack or this percent risk of a stroke. So that's how we're able to standardize it across all different people at all different ages over all different times. And so we bring that as a way in medicine to kind of stratify risk and work with patients to help modify any of those factors that we can.
Amazing. Thanks,
Great
Gabby.
question.
Um, Another question that we got before the webinar, one of our registrants asked, how does menopause affect heart and brain health?
Oh, menopause. Again, one of the things of privilege of getting older. So menopause is in its basic form, it is unfortunately the loss of estrogen in people who are assigned female at birth, right? Over the course of time. So essentially your supply of eggs, right, um, is on its way out. And so the body naturally starts to lose estrogen. Estrogen in its glory, when you're in your teens, 20s, 30s, 40s, almost into 50s, is the hormone that helps keep blood vessels flexible and manages what we call the bad cholesterol. So as your estrogen decreases, as a result, your arteries become more stiff because estrogen is one of these things that helps, again, keep those blood vessels flexible. So the less estrogen you have in the body, the more the arteries of the body become more stiff. And that is a direct result, and that causes, excuse me, a direct result of a higher blood pressure. So number one, women as they're in menopause, it starts off perimenopausal, and then you're in menopause and postmenopausal. So in that transition in the late 40s, 50s, and 60s, women may notice their blood pressure goes a little higher. And that's because the estrogen is starting to slowly fade away. The other part about it is that estrogen increases or changes the weight distribution in women. So, typically in women, weight is predominantly in the hips, right? Because it's meant for us to have babies. But as we start to, again, lose that estrogen, it starts to fade away, the weight then gets more distributed to your abdomen. So we call the adipose or visceral fat. And the more weight that you carry in your belly or your abdomen, the higher or worse of you get a worse insulin resistance. So your body's ability to utilize insulin and to break down glucose over time is not as efficient. And so when we see patients, we always recommend decrease abdominal fat in this context. Lastly, again, as estrogen starts to go down, your ability to metabolize glucose also goes down. And that feeds back into that idea of getting uh, fat essentially redistributed to your abdomen. So that's the very basic, 3 points about estrogen in general. There's more to it, but unfortunately, that's something that women struggle with. So I've had many patients say, my weight's gone up, I'm still exercising, I'm eating healthy. Sometimes people try to eat too less calorically because they're trying to fend off that weight, and it's just part of the natural progression of going through menopause. There's not much you can do except I recommend lifting weights to prevent osteoporosis, which will help you all as you get older with fall. God forbid you fall. So weight bearing exercises, exercising in general, that's the biggest thing you could do, and eat healthy. Eat enough calories, don't starve yourself. And again, some people try to do that and it winds up causing people to not activate their metabolism enough, whatever's there. Um, you could also talk to your GYN provider or your primary care provider about hormone replacement therapy. A lot of times that helps patients with their symptoms for menopause. Um, and so that I've had patients have great success with that if they're, eligible for it.
Amazing. So we have time for one more question, I think. Um, from the chat, Natalie asked, how often should HbA1c and cholesterol be measured? So if you
Great
could go
question.
into like what, we talked about the numbers, but how often should we be checking on these numbers?
Great question. So I think it depends on how old you are. And I think that it also depends on if you fall into the pre-diabetes, high cholesterol categories. So typically for adults if you have been diagnosed with diabetes or you're pre-diabetic, they typically will measure your A1C every 3 months, or to every 6 months, depending on if you're on medication or not. If you're on medication, like the new injectables that come out, they might want to monitor you sooner because they want to make sure that your A1C is not getting too low with the new medicine. So it's kind of like finding the sweet spot with that, like finding the perfect pair of heels or sneakers, right? You got to find what medication combo works best if you need them. If you don't, then again, it's typically, again, if you're pre, it's every 3 to 6 months. If you're not, if you're just, if you're 40 years old and you've got no risk factors, they probably will do it every year. And that's, I think, at least you should do it every year. Um, again, if you're maintaining weight and exercise and diet, etc. So at the minimum every year, and again, depending on if you fall in the other categories, could be every 3 to 6 months. What was the other part of the question? Sorry.
Sorry, I had to unmute. How often should cholesterol be measured?
Same thing. So I think
Yeah.
it's appropriate to do it every year. Unless you are having high cholesterol and they want to start you on a new medication, then they might do it a little bit quick, every 3 months, every 6 months, depending on what medication you may have to try. We don't want, if it, usually a provider will tell you, okay, you've got pre-diabetes or you've got pre-high cholesterol. Let's do a modifiable risk, right? So they're going to tell you to eat a little healthier. They're going to tell you to increase your exercise. They're going to tell you to modify your diet. And they'll typically have you come back in 6 months, I would say, because they don't want this to go on for too long, where you then start to potentially have long-lasting effects from having uncontrolled cholesterol, you know, A1C, blood sugar, uh, hypertension, et cetera. So, yeah, but at least once a year for sure.
Okay, amazing. Well, we got some really great information. I'm sorry that we couldn't get to everyone's questions. I am putting that link in the chat again to learn more about our heart health content. And this QR code on the screen goes to our request an appointment form for Weill Cornell neurosurgery. So you could actually get an appointment with Gabby or one of our other amazing NPs or surgeons or PAs. Thank you so much for doing this. I feel like I learned a ton. I think that everyone in the chat learned a lot. So we really appreciate it. Thank you.
My privilege. Thank you all for joining and listening in. And feel free again, like Rebecca said, to make an appointment with us if we need, if you want to chat more. And have a great night and hopefully no more snow.
Yeah. All right. Wonderful. Have
Take
an
care.
amazing night. Thank you.
Bye.